start. Okay, good evening, everyone, and welcome, and thank you for joining Journal Club tonight. Tonight's topic will be external ventricular drainage, a nationwide prospective multi-center study of external ventricular drainage accuracy, safety, and related complications. Our presenter are Arba Sesia. She is a Master of Public Health. Moderator is Dr. Emal Leisha, neurosurgery resident, and neurosurgeon Dr. Gentian Toshkezi. Arba Sesia is a graduate of George Mason University with a degree in neuroscience and biology. Following her undergraduate studies, she pursued on Masters of Public Health from the George Washington Milken Institute School of Public Health. Arba is currently a first-year medical student at Loyola University Chicago Stritch School of Medicine. Dr. Emal Leisha is a neurosurgery resident at the University of Tennessee Health Science Center in Memphis, Tennessee. He obtained his medical degree from Tufts University School of Medicine in Boston, Massachusetts, before moving to Memphis for his neurosurgery residency training. He has worked with multiple Albanian non-governmental organizations inside and outside the US during the past few years, and is currently a board member of Albanian Fighting Cancer. And Dr. Gentian Toshkezi graduated with gold medal from University of Tirana, Albania. He specialized in neurosurgery in Paris, then fellowship in neurosurgery at Boston Medical Center. He finished his residency and spine fellowship at SUNY Upstate Medical Center in Syracuse, New York. He is currently working at Thomas Jefferson University Hospital in Philadelphia, performing a variety of neurosurgical intervention to brain and spine. Dr. Toshkezi has more than 100 publications, chapters, and platform presentations in national and international meetings. Very impressive, Dr. Toshkezi. He also was awarded Top's Neurosurgeon 20 in 2020 in Pennsylvania. In April 2022, he was awarded from President of Albania the medal, the Knight of the Order of the Flag. Recently, he was awarded from Albanian Community in Philadelphia, Honor of Albanian Community, for the support he has given to Albanian community. Well, thank you, everyone. So we can start. I believe Arba will start the presentation.
Yes. Emal, can you share the screen, please?
Yes. Can you guys give us access to? Oh, yeah, perfect. All right.
Great. Thank you so much. I really appreciate it. Hello, everyone. I'm Arba Sesia. I'm very excited to be here and present the article on external ventricular drainage, and I look forward to engaging with you all in a discussion afterwards. Next slide, please. So I'm going to give a brief introduction of cerebrospinal fluid and hydrocephalus before we dive into the article. So cerebrospinal fluid is a clear fluid that's produced by the choroid plexus in the lateral ventricles and the roof of the third and the fourth ventricle, and is released in the subarachnoid space. Its functions include mechanical support, cushioning the effects of the CNS on the CNS and dampening the effects of trauma. Normally, we produce about 500 milliliters of CSF per day, which is more than we need, and we only need about 90 to 150. So we are constantly changing the volume of CSF up to 5 times a day. The extra volume is drained through the arachnoid villi into the venous sinuses. Arachnoid villi are these outpouchings of the arachnoids that extend into the dural venous sinus and act as a one-way valve for the flow of CSF from the subarachnoid space into the venous sinus. Under normal conditions, the CSF is in a dynamic balance between production and reabsorption. Looking at this picture here on the right, we can trace the flow of CSF from the choroid plexus in the lateral ventricle to the foramen of Monroe, the third ventricle, the aqueduct of Silvus, the fourth ventricle, and foramen of Luschka-Magenti, subarachnoid space of the spinal cord and the brain. As we see, it's kind of bathing the brain, and then the arachnoid villi, draining onto the superior sagittal sinus and returning to the venous circulation. The picture here on the bottom shows the arachnoid villi poking through the arachnoid layer and draining into the venous sinus. Next slide, please. As I mentioned previously, it is essential to have a balance between production and reabsorption of CSF. However, this equilibrium can be impaired, and it results in accumulation of CSF within the ventricles. This condition is known as hydrocephalus, and it causes the dilated ventricles and increased intracranial pressure. There are two main major categories of hydrocephalus: non-communicating and communicating. Non-communicating results from obstruction of the flow within the ventricles, and communicating is caused by an impaired CSF absorption in the subarachnoid space. This is usually the case for subarachnoid hemorrhage and meningitis. In addition, we have different types of hydrocephalus: congenital, acquired, and normal pressure. Congenital is a buildup of excess CSF at birth. It's often caused by a brain malformation or a birth defect. Acquired occurs after birth and is the result of tumor, injury, or disease. And acquired hydrocephalus is what we're going to mainly be talking about in today's article. And normal pressure is CSF accumulation, but the pressure remains normal despite the excessive CSF fluid. The picture here on the left shows an MRI scan of a brain with hydrocephalus, and it's shown by the enlarged ventricles due to CSF accumulation. And we can compare it to the one on the right, which is a normal MRI of a brain. Next slide, please. So acute hydrocephalus is often caused by severe traumatic brain injury, subarachnoid hemorrhage, and intracranial hemorrhage. Here, when we are talking about intracranial hemorrhage,
Hey, Arba, I'm going to stop you for 1 second, just for the students in the journal club, just to show them a little bit, the scans and what is the ventricle, what is the brain.
Sure, of course.
So as Arba said, this is an MRI, and basically all of these. Can you guys see the pointer, by the way?
Yeah, we can see it. Okay,
perfect. So this is the matter of the brain. So this is basically the brain. These this tissue that's marked in like gray, darker gray, and then these spaces that are dark, that's the ventricles, and those spaces, as Arba said, are filled with fluid, which is called the cerebrospinal fluid. And as you can see, this is a normal scan, right? There is a balance between the amount of fluid and the amount of brain within the skull. And this scan shows an overall like normal person. There is most of the space is filled by the brain, and then there is within that area there's some space that are filled with the CSF. And then in this picture over here, as you can see, the fluid filled, the ventricles, the fluid filled space is like much larger. And one thing that I wanted to mention is that there are people that actually have a scan that looks like this, meaning that they have these fluid filled spaces that are very large, but they do not have symptoms. And if that's the case, we do not call that hydrocephalus. We just call it ventriculomegaly, meaning a person that has big ventricles. A patient, we call it hydrocephalus when a patient has a scan looking like this, and they have symptoms. And symptoms can vary. Patient can be lethargic, more fatigue, difficulty with balance, all kinds of stuff. So just some small teaching points that me and Dr. Toshkeza are going to be talking along the way.
And Ermal, you explained very well. 1 second. Just to clarify for the audience, you have to say that is a sequence of T1, T2, because they might see the CSF in another image on MRI, which might look differently, but it's still cavity, and you explained very well on that image that how that looks, like the ventricles and the CSF. So that might be bright on a different sequence.
Yes, absolutely. Yeah. So there's basically T1 and T2 sequences of an MRI, and this is a T1 sequence, and we know that because the fluid is dark, and on the T2 sequence, the fluid will show bright. And over here, this is a CT scan. And here, basically, again, these are the ventricles. They're larger than they should be. And fluid is dark on CT, especially. So the darker is basically closer to the density of water. So CSF is basically is very similar to water, meaning it's basically like water with a few solids in it. So that's why it shows dark. So this is a CT scan. This is the brain. This is the bone. This very white thing, and then the CSF is dark. All right, Barbara, back to you.
Thank you so much, Ahmad. So as I was saying, these acute hydrocephalus is often caused by severe traumatic brain injury, subarachnoid hemorrhage, and intracranial hemorrhage, specifically the intraventricular hemorrhage. The blood clots are the ones that obstruct the CSF flow, and they result in increased pressure. Next slide, please. One of the most common and life-saving procedures performed in the emergency room are neurological intensive care unit in order to decrease this elevated intracranial pressure in patients with acute hydrocephalus or ventricular hemorrhage is the external ventricular drainage, or EVD. This illustration here provides us with an understanding of the EVD catheter insertion procedure. As we see here in this picture, the patient's head is elevated at a 45-degree angle in the supine position. The hair is removed. Sorry about that. The hair is removed and the scalp is cleaned with an antiseptic solution, and it is anesthetized at the area of incision, which is just behind the hairline. A small hole is drilled through the skull, specifically at what's known as the Coker point, which is located about 2.5 centimeters from the midline and 11 centimeters posterior to the nason. The catheter is inserted into the brain, into the frontal horn of the lateral ventricle, while the distal end of the catheter is connected to an external collection bag at the patient's bedside. So EVD is very useful for decreasing and monitoring the ICP by draining the excessive CSF and ventricular blood. And in the case of meningitis, it drains infected CSF. However, it's important to mention that there are risks and complications associated with the procedure. For example, hemorrhage, particularly during the procedure, misplacement, and then we have blockage of the catheter and infection. Next slide, please. So now we're going to jump into the article. So the study was conducted the aim of the study was to examine the EVD catheter related complications, including catheter infection and malposition, and investigate the associated morbidities and the risk factors using a prospective cohort, and to address the inconsistencies that are reported in the literature, particularly retrospective studies. Next slide, please.
Yeah. About one more thing again, just to kind of explain like this in a little bit simpler terms what the purpose of the EVD is. So if you go here, basically this patient has big ventricles, meaning has a lot of fluid, and assuming he also has is symptomatic from it. Can also have blood in this space, which makes it even worse. So simply the role of the EVD is basically to put this catheter right here through the brain, through the skull, through the brain, and have it in this fluid filled in the ventricle, this fluid filled area. And there's more fluid or there's blood, and what the EVD is doing is taking it out temporarily, until we figure out what's going on, or until we figure out a better way of how to fix this permanently. So so in very plain terms, EVD, you put the catheter in to take the fluid out, decrease the pressure, take the blood out, or in and in most of the cases, the catheter tip can also sense, can measure the pressure within the ventricles, and you can give us an idea of what the pressure is for this patient. And the other thing is that we mainly, in most places in the country and in the world, this is a bedside procedure, meaning that you do it at bedside. And in a bunch of places, they actually take this patient to the OR to do the procedure. It's very quick. Depending on who does it and how many they have done, it can take from 15-20 minutes to like an hour to do one. As Arba said, there is a certain measurement that everyone uses to place this in the right spot. Ideally this has to be in the lateral ventricle, near the foramen of Monroe. And if you want to put it on the right, ideally you want to put it on the right and not have this transpass and go through the other side, a little deeper than it should, because obviously there's important structures within the brain. So if you push this too deep, you can injure areas, you can injure blood vessels. If you put it too shallow, it's not going to work well. If you put it within brain tissue, it's for sure not going to work. So basically this paper is trying to look at some of those stuff.
Thank you so much, Mali. So the study design of this was a prospective multi-center observational study, and it was conducted in 8 academic neurosurgery centers. There were about 348 patients that were enrolled from the beginning of the study till the end. To be eligible for participating in the study, patients had to be enrolled within the 48 hours of EVD catheter insertion, and the catheters had to be inserted at the bedside or in the OR. Patients that had to present with an acute life-threatening hydrocephalus and not with a planned procedure. And the study also included patients younger than 18 years old. So moving on to the exclusion criteria, as I previously mentioned, patients undergoing planned procedures were ineligible to participate, and patients presenting with pre-inserted CNS infections were also excluded from the analysis. Next slide, please. So in terms of data collection, clinical, laboratory, and radiographic data were entered into standardized forms as part of the global research platform database, and it included procedure-specific characteristics at the time of catheter insertion, such as the measurement of the length of the skin incision and the tunnel portion of the catheter. Next slide. Now, I believe it's important to go over the definitions of complications as they're defined by the authors of this article. Ventriculitis is defined as EVD catheter infection plus the clinical signs of meningitis. ECI, or EVD catheter infection, is defined as CSF biochemical profile, which is indicative of an infection, and more than one positive results of a CSF culture. And suspected ECI is defined as CSF biochemical profile that is suggestive of infection, but it has an absence of positive results of a CSF culture or gram stain. And I'll talk more about the definitions and the relevance of the grade placements when I discuss the results. Next slide, please. So data analysis was performed using SPSS. Categorical data were summarized as proportions and frequencies, while continuous data as mean and standard deviations. And these are some of the statistical tests that were performed as well. Next slide, please. Now, moving on to the results of the study, about 48% of the study populations were female and the rest were male. The mean age was around 57 years old, and aneurysmal subarachnoid hemorrhage was identified as the most common etiology that required an EVD catheter insertion. Next slide, please. In approximately 57% of the cases, the EVD catheter insertion was performed by PGY-13 neurosurgery residents. The procedure was completed at the patient's bedside in more than half of the cases, and image guidance was not largely used, and the majority of catheters were inserted via freehand technique. And only about 1.1% of the catheters that were inserted were antibiotic impregnated catheters. Next slide, please. So now I'm going to talk about the grades of EVD catheter tip location. So EVD catheter tips are graded or classified based on their location in the ventricle. So grade 1 is considered the optimal placement. It has 100% functionality, and it refers to the insertion of the catheter on the foramen of Monroe, as Demal previously also mentioned, and the ipsilateral horn of the lateral ventricle. And this was about 61% of the patient population had a grade 1 EVD catheter tip location from this study. Grade 2 is considered a functional placement and has about 99% functionality. And it refers to the insertion of the catheter tip on the contralateral ventricle or the third ventricle. And about 25% of the patients of this study belong to this category. And grade 3 is considered the suboptimal placement. It has about 76% functionality, and it refers to the insertion of the catheter tip in the basal cistern, basal ganglia, or brainstem structures. And about 13% of the patients were part of this category. So this MRI image here on the left shows the grade 1 placement, as we see here on the ipsilateral horn of the lateral ventricle. The B image shows a contralateral insertion, which would be classified as grade 2. And the third image shows the grade 3 catheter tip location.
So, as Arba said, these are 3 CT scans basically, and we honestly in practice we don't really discuss this grade 1, grade 2, grade 3. It's just like, you got it right or you didn't. But I think for the purpose of studies and these sort of evaluations, it's important to I guess to have these to have this grading system. But one other thing that I wanted to mention is that for most patients, we try to put this catheter on the right side, and as most of you guys know, on imaging, the right side is here, and this is the left side. And we try to put we try to do it on the right side because on most people, the left side of the brain is the dominant side that controls things like speech and understanding. So even though the procedure is overall low risk, if we were to take the risk of putting it, we'd rather, and if there is any chance that we could injure something, we'd rather do it on the right side rather than on the left. So in simple terms, ideally this is how the catheter should look. And on the second scan, they basically, they went a little bit too medial. They basically pushed the catheter literally through brain tissue, through the septum pellucidum, and they went all the way to the other side. Does it matter? Well, I mean, ideally you shouldn't have done that, but if the patient is okay, and especially if the catheter works, then it's fine, and that's what this means here, 99% functionality, meaning that even though you place that catheter, completely in the opposite ventricle that you want it to, at least it works. It can still measure pressures, it drains well, so it's fine. And then on the third case, the catheter is completely in brain tissue. It's not even touching the fluid or the ventricles at all, so it's not going to work because most of the fluid is located within the ventricles, and even though there is a little bit of fluid, within the brain, that's not the purpose that you're putting this catheter for. And what the results of the study showed is that they basically got it right in only 60% of the time, and 25% of the time, whoever put the catheter, they put it contralaterally, and 13% of the time they didn't even get fluid. So that's kind of what the results of the study mean in kind of.
And Arba, did they include the patient with more than one EVD? Sometimes they get more than one bilateral EVDs.
So I believe they included, those patients basically where they got it wrong the first time, and they had to put a second catheter to get it right, so.
But not bilateral EVDs, right?
I'm not sure that they specified that.
Yeah, they didn't specify exactly.
Yeah, sometimes we do bilateral EVDs, especially when there's blood in the ventricles, in the third ventricle, and is not enough. One EVD is not enough to drain or get blockage. So in a lot of places we do that. We put 2 EVDs, but maybe they excluded these patients, but they don't mention it.
They talk about later in the article about replacing the EVDs and if that has an impact on the patient having a recurrent infection or not. So
perfect. That's okay.
So moving on to the results, no association was found between a specific etiology and the grade 2 or 3 insertions. Midline shift, which is the displacement of the brain tissue across the midline, which can be caused by TBI, elevated ICP, or intracranial hematoma. This study found that patients that had a midline shift experienced grade 2 or 3 insertions more frequently than patients without a midline shift. And also the extent of the midline shift was greater in patients with grade 2 or 3 catheter insertions. In addition, the study also found that most of the grade 2 or 3 insertions were performed by attending physicians, but there were no associations in terms of, grade 2 or 3 insertions, catheter insertions, and image guidance. Next slide, please.
Yeah, so again, sorry, because I'm again, just to, and you're doing an excellent job. I'm just kind of jumping in just to explain things, just a little bit simpler for some of the folks in the meeting. So basically, what this means is that the more senior residents, the more experienced people got more of the catheter placements wrong. And, if you hear that, you're like, whoa, that's not good. Why is that? And I think their explanation for it is that most of these catheter misplacements happen in the more complex cases, patients where there was some sort of mass or edema and the brain, and there is a brain shift, meaning that instead of, like those scans that we showed before, where, the right side of the brain is on the right and the left side of the brain is on the left, because there's some swelling or some sort of, mass effect, the location of the ventricle is not how it should be, because the brain is not how it should be. So basically what they're saying is that, the more experienced people got more of these higher grade, meaning misplaced catheters, because they try to do the more complex cases, and that's the reasoning for it.
That's a good explanation, Ermal. I would say also that EVD is done mainly when you are PGY 2 and 3, because you take calls and the emergencies are more often
exactly
during the night. I called EVD as like the main procedure for the person who's on call at night, and resident of PGY 2 and 3 gets the most of EVDs. And by the time you are a chief resident or senior, you don't get to do much. And I think EVD is an experience. It's a procedure that is done blindly, and it's everybody wants to get it right. Every neurosurgeon wants to get it in the right spot, but it's a procedure that is simple, but also can be difficult.
Yeah, and you know, the tendency is, you know, when you see a patient that has like a, you know, like a situation where they need an EVD, but you know, just kind of the situation is a little bit more complex than normal. You know, the tendency is, you know, for the senior resident, or you know, depending on the hospital they're attending, you know, being like, you know, this is a hard one, let me do it. But you know, as Dr. Toshkeza said, it's you know, it's the junior resident that actually gets to do most of these procedures. It's just how it works. You know, the senior residents spend most of the time operating, and the junior residents spend most of the time doing this sort of procedure. So, you know, they obviously have more experience with it. You know, probably between your first and third years, you probably put like 100 EVDs, and between your fourth and 7th years, you probably put like, you know, 5. So, you know, you don't forget how to do it, but you kind of, you know, there are certain nuances of putting this, and you know, certain feel to it that you gain by doing this like over and over and over and over again.
You put the 5 that the junior resident fail, so those are the difficult ones.
Yeah,
right?
Yeah,
so,
absolutely.
So the percentage is really not that great of the failure. But anyway, let's I don't want to interrupt.
All right, but you can go on. Sorry.
No worries. Can you go like a slide before this? Okay, one more after this. I'm sorry, I just got confused. Thank you so much. So EVD associated like intracranial hemorrhage occurred in about 10% of the patients, and 8.5% of them experienced the tract hemorrhage. ICH occurred around like 3 days after catheter insertion, and it was associated with heparin use and catheter replacement. About 27% of the patients requiring catheter replacement experienced an ICH compared to the 10% who didn't. Admissions, diagnosis, operator experience and use of image guidance, catheter tip position. These factors were not statistically associated with the development of ICH after EVD insertion. Next slide, please.
Sorry, 1 second.
No worries, take your time. So about 9.5% of the patient experienced infectious complications after an EVD insertion. 2% of the patients experienced ventriculitis, 3.6% a confirmed EVD catheter infection, and 4% a suspected ECI. Suspected ECI and ventriculitis were confirmed 9 days after catheter placement. These patients experienced a longer duration of catheter placement, about 18 days, while patients without one had an 8-day duration of catheter placement. Another factor that was associated with catheter infection was the setting where the procedure was performed. So a significantly higher proportion of patients with catheter infection had their procedure done at the bedside compared to the OR. And I will discuss the reasons behind this when I talk about the discussion portion of the article. And in addition, incisions that were less than 1 centimeter were associated with infection. Next slide, please. So now moving on to the discussion portion. So the goal of this study was to better understand the modifiable risk factors and use this knowledge to enhance the safety and the accuracy of the EVD catheter insertion. So this is a first study to use a prospective cohort data from a multi-center observational cohort. So it was definitely one of the strengths of this study. As I previously said, the rate of grade 2 to 3 misplacement was 38.6%, and which was compared to the literature reported value of 23%, so much higher. Previous studies also suggested using an image guidance as a way to decrease the rate of catheter misplacement, but this prospective study did not find an association between image guidance and catheter misplacement. but it's definitely necessary to further examine this potential relationship in future studies, as one of the limitations of the study, as I will discuss later on as well, was that only a smaller portion of these cases underwent insertion with neuronavigation. There was no association between catheter insertion accuracy and resident level of training, but it was reported that a significantly higher proportion of grade 2 and 3 catheters were inserted by attending physician, as we previously discussed. And as Emile also said, the authors suggested that this association might be potentially due to the more challenging cases that were taken by the attending physicians. Next slide, please. So according to the previous literature, there is a 0 to 34% risk of intracranial hemorrhage with EVD catheter insertion. And this prospective study corroborated these previous findings. Patients that were using heparin for DVT reported increased risk of ICH, but definitely more research needs to be done to better understand this association. One important finding that was that a higher proportion of patients who underwent catheter replacement develop ICH without decreasing the rate of infection. So the findings of this study suggest that routine catheter replacement maybe should be discouraged. The rate of ECI, EVD catheter infection is reported to be up to 45%, but there is a wide variability from study to study, and this can definitely be due to a difference in the setting and technique of catheter insertion and different definitions of infections. So in 2017, there was a survey that was done by AAMS, the American Association of Neurological Surgeons, that showed considerable heterogeneity in the practice of EVD insertions. With approximately half of the responders, they reported utilization and adherence to a protocol for EVD insertion. So I believe it's very important to use a protocol that the physicians and residents adhere to as a way to potentially reduce the infection rates. Moving on, this prospective study reported an ECI rate of 9.2%, typically 9 days after catheter insertion. So these findings were comparable to the findings of the largest analysis of ECI that was conducted in the UK and Ireland, which reported a 9.3% rate 8 days after insertion. And another finding of this article was that the association between a smaller skin incision, less than 1 centimeter, and ECI. This might be due to the contact of the epidermis of the skin with the instruments and the inside of the brain, which results in an infection. So having an incision greater than 1 centimeter might be beneficial in avoiding infection. Catheters that were inserted at the bedside as compared to the OR were associated with a higher rate of infection. This kind of makes sense because the bedside setting is less sterile environment than the OR. So one of the takeaways from this study is to aim for placing the catheters at the OR whenever it's feasible, and to optimize the sterile setup of the bedside. Finally, this study found no reduction in infection with usage of antibiotic prophylaxis. So finding that was not supported by previous literature. So this result is significant, as it definitely suggests that to not delay the catheter insertion until the antibiotics are administered. Next slide, please.
Yes, so I'm just gonna summarize, just kind of explain a little bit some of the stuff that you talked about, Arba. So basically, this procedure, the EVD placement, we do it all the time. I'm not really sure how many are done per hospital, each year, but I bet you it's, probably, depending on the hospital, the volume of the hospital, it could be as many as like a couple hundred or more a year. It's overall pretty safe, but there are risks with it. And the two main risks of the procedure: one is you can cause bleeding, and two is that the catheter can get infected. You're passing this catheter through the brain, and you're doing it blindly, meaning that you don't know whether you're passing this through an area that has no vessels, or you're pushing this through part of the brain that has like, a vein or, a small artery, and you're putting the thing like literally through the artery. So one of the one of the risks is that, you basically put the procedure, it works great, and then you get a scan the next morning, you see that there's blood, there's all of a sudden blood now within the ventricles, or sometimes just in that area of the brain where the catheter passed, and that's called the tract hemorrhage. Most of the time, it's not a big deal. You're like, oh, it's a tract hemorrhage. The EVD, EVD is working. The catheter is working well. Patient is doing fine, and even though you're causing some bleeding because the catheter is there, it's kind of tamponading itself, so nothing bad happens. But there are times where the bleeding can get out of proportion, and it can cause like a big intraparenchymal hematoma in patient, and that can lead to kind of subsequent, patient needs a surgery or something like that. But that's very rare. So it's obviously important to look at that, because if the patient is on very heavy blood thinners, you kind of have to think about it. If the patient is on Plavix and like Brilinta, or an aspirin, or like patient is is coagulopathic because they have like liver failure, you have to consider these things, because if you put this catheter in a patient that is under these conditions, the risk of you causing a bleed is much higher. So you have to take into consideration. You have to, ideally, in most places, people wait and try and fix the coagulopathy, or reverse the blood thinner before they put the catheter in, because the risk of causing a damage is much higher than the benefit of actually putting the EVD. The other thing that can happen is an infection. And most of the time, the infection happens because the catheter is sitting too long within the brain and the ventricles. And as Arba said, you're most of the time you're doing this at bedside. So there's always a chance that you're going too fast, or you're not paying attention. You touch something that's not sterile, and then you're touching that catheter that's going in the brain, and so there's a lot of ways that you can induce an infection if you do it at bedside versus if you do it in a control setting in the OR, where everything is sterile, someone's handing you the stuff. That's one thing. So it makes sense that the rate of infection is kind of measured several days after the EVD is placed. This is important to measure infections in EVD placements, because if the infection starts involving the actual ventricles, you can get ventriculitis, and that is actually very severe, and patients can die from that. And that happens very rarely, but it can happen. And if it happens, you kind of have to figure it out as soon as possible, so you can start the patient on proper antibiotics. And thankfully, because you have the EVD place, you can pull some fluid out and kind of analyze it to figure out what is the actual bug, and give antibiotics according to it. But you also have to pull that catheter out if that's the case, because now that catheter is obviously contaminated. And if you pull the catheter out and the patient still needs the catheter, then you have to put another catheter in. And same thing with those patients where when you're putting the catheter wrong. If obviously you put the catheter in and it's not working, well, guess what? You haven't fixed the need that the patient has, so you have to put another one in. So these are just some things that I want you guys to keep in mind as you think about the EVDs in general and the results and the conclusions from the study.
So now we'll just go over a few limitations of this study. Ventricular size was not evaluated, which if it was, would have strengthened the analysis of the study. Subgroup findings should definitely be interpreted with caution due to their small size, specifically the antibiotic impregnated catheters and the image guidance findings. In addition, the length of the skin incision and the tunneling were subjectively estimated by the operator. So there was no objective measurements that were taken during the procedure. And the study did not include any follow-up longer than 24 hours after the catheter removal. So can say that the conclusions are short-term. Next slide. This is the citation of the article. And thank you so much for your attention. I look forward to any questions you have.
Great job, Arba.
Very good, guys. Arba and Arman, you did a great presentation of the EVD, which is it's as simple as it is, can save life of the patients. It's an emergent procedure, and it can be also complicated, as we discussed the complications through this study. So I think Arman and Alba explained very well the key points of the study and also explained the EVD. And I think whoever has a question, some of the questions I saw on the chat and I tried to answer. But
yeah, thank you, Dr. Shkezi, for doing that, for answering questions. One thing I want to point out is that we chose this article because you know, we wanted to make this as, you know, as a great learning experience for all of you guys. And you know, EVDs are something that, you know, a lot of you guys will see, whether you're, you know, internal medicine or cardiology or general surgery. You'll see a patient that has this on the head, and you know, sometimes, you know, this is your patient, you know, you want to take this patient for another procedure, and you're like, oh, you know, it has an EVD on the head, you know, do we have to wait? So at least, you know, by kind of understanding why we do this, what are the risks associated with it, and some of the things that we think about when we do this procedure, you know, you guys know a little bit more about it. And when you talk with neurosurgeons at your hospital, they don't give you shit anymore because you know what you're talking about. Do you guys have any questions?
Yeah, well, first I want to thank you, everyone. You did great job. Arba, I don't even know, are you a first-year medical school? It's like it was, you know, fantastic. Really, really great presentation.
Thank you so much.
So I'm really surprised with this 45% infection rate on the study. I mean, we do have infectious, the central line infections in the hospital, but they're not that common. But 45%, like, you know, would it be like, do you guys do it by the bedside, or because you don't have time to take the patient to the OR, or what is the reason of this?
so Nora, mainly, Arman mentioned a little bit, and we discussed that the EVD is an emergent procedure, is done in the middle of the night. To open the OR, it requires an attending to come from home.
Yeah.
And so I think it's a procedure that saves the life of the patient if you just do it. So most of the time is done at bedside in the ER or ICU. And the risk of contamination is quite high in those settings when you do that EVD, and especially you do it under pressure. You do it when a patient is coding probably and is gonna die. So you have a lot of pressure to just get it done.
Right.
And in those situations, I think the main reason of the infection is that you know, it can get contaminated in the rush of doing that procedure. On the other hand, it stays longer than the lines, I think, and you know, it stays at in the brain, and it's a direct communication of something that it should not communicate with the surrounding. As we know, the brain and CSF is in a closed box, and there shouldn't be any communication and contamination. And placement of the EVD creates this kind of opening to the air and to the outside world of the brain, although the EVD is a closed system, and should remain closed. There are a lot of other factors that we study today, that probably the contamination comes from opening the EVD or trying to set sample, you know, with a you know, get CSF every 2-3 days. So a lot of people are looking into it where they should minimize the contamination of this closed system. And the EVDs for especially subarachnoid hemorrhage, they stay long, and it's something that can happen. So I agree with you. It's a high rate of infection for the EVDs.
Yeah, I think, I'm sorry, just to clarify, I think there must have been a typo because it was 9.5%, not 45%.
The 45% was the literature reported range from 0 to 45, but
Okay. Yeah,
this
that's
study reported 9.2%.
Whoever had that 45%, I don't know what the hell they were doing.
I know, I'm like,
That's a high
Okay.
number, but yes, that can be the breach of the of the.
could come there, huh?
Yes, it
Yeah.
can come to that.
One more question, intracranial hemorrhage. Now you have a patient with intracranial hemorrhage and then you put the EBV catheter. Is there a protocol not to go with a high pressure, like slowly to leak so it wouldn't cause any other problems? Or you just put it and, just remove it, evacuate the.
No, you don't evacuate. Actually, that's a good point. When you have a subarachnoid hemorrhage and you have an aneurysm that has ruptured
Yes.
brain, this aneurysm can continue to bleed, right? And placement of the EVD and the pressure in the brain itself builds up and creates like a tamponade effect on the aneurysm itself, so it stops the bleeding. So you want to release the pressure, you place an EVD, but you don't want to release too much because then the bleeding is going to continue. You remove the tamponade effect of the EVD. So on those cases, we do like we have done a deal. We put the EVD setting at 20, 15 or 20, depending on the place where it is, until the aneurysm is secured and we don't have any more the risk of rebleeding from the source. So I wanted to mention that it's a closed system. I mentioned that, but also we have a setting of the drainage for the EVD. So we leave it at high setting when there is a risk of continuous bleeding. And we go to the lower setting when we want to drain the blood. So once the aneurysm is secure or the bleeding source is secured, then we go to the lower setting and we have this drainage of the blood, which doesn't happen immediately. It takes days and days. It takes time. And then we go, it was a question on the messages, do they require shunt? Then we go to the other step. We do, after we drain the blood, we see the patient doing better, and we raise the EVD to the point where it's 15 or the normal and 20, and then we clamp it. And depending on the place, we clamp it for 1 or 2 days, and we see if the patient does well. So he tolerates the clamping trial. And if he does, then we remove the EVD. We get a scan before, a scan after. We see no changes, no hydrocephalus. We see the patient doing well. We continuously monitor the pressure. The EVD also has another role in the trauma especially, but also subarachnoid. We monitor the pressure of the brain. And that's great. We do it here in the US. In Europe, they did not do that. They have different ICP monitors differently. And so we have we do it for 2 reasons. One, we monitor the pressure. The second, we treat the pressure. We release the pressure through the CSF. And if the patient doesn't tolerate the trial, that means that we can retry that just to not put the pressure through the shunts, or we are sure the patient needs a shunt and then he goes through the permanent shunting, ventricular peritoneal shunt. And there is a 20-25% of patients with subarachnoid in literature that requires shunting. They fail the trial. So
Yeah, thank you.
that's the EVDs.
Yeah, and also as Arba mentioned, the body produces about 500 cc's of CSF per day, which means that technically you should not lose more than 20 cc's per hour, total day, because if you do, then you're basically losing more CSF than your body has. So we basically, when we put these EVDs, we advise with that, we basically, talk to the nursing staff that basically they cannot let more than 20 cc's off per hour, because if you drop 30 every hour, then you're losing what, like, 400 cc's of fluid. Like what would be 600-700 cc's of fluid. That's physiologically that's not possible. So there is a limit of how much fluid you can drain, basically per hour.
And in the trivia, there is the 500 that Ermal mentioned, the cc of CSF that body produces and absorbs, is equal to what, if anyone can compare in the body, is equal to the fluid that we lose with respiration, with the respiratory function in 24 hours. Apparently, I read that in trivia questions. Thought it was interesting. But yes, the body produces and absorbs, but when it's a problem with absorption or overproduction or mechanical blockage, then EVD and then shunting are the solutions that we have today. So it's not uncommon in neurosurgery. It's very simple procedure, and I think every doctor in the hospital has heard about the EVD placement and the shunts.
All right, well, I guess thank you. If no one has any more questions, thank you for listening. I hope we didn't bore you too much with this.
In contrary, you piqued my interest a lot.
I do see some hands up. Did anyone have a last minute question?
I don't have a question, but I have a
yeah.
thought. I know we're like 1 minute, but
No, it's not.
Please, yeah.
Don't worry
okay, so
about
like from researching the literature, I found that most of the EVDs and regarding EVDs, most of the skin incisions are done like in a linear fashion. So like the burr hole is drilled below where the flaps of the skins meet, which I think might predispose the patient to infection. So like one of my thoughts was like, why not change the shape of the skin incision? Like for example, have like a horseshoe or like a U-shaped incision, like, and drill the hole in the middle of the skin, so you don't have like direct exposure of the skin with the burr hole. And like the tunnelization is done like towards the posterior end of like the uncut skin. So this way you kind of limit the contact with the cut skin. So just a way.
Yeah, the only thing with that is that it's not feasible, because when you do this procedure, you make a skin cut like this, and then you basically, so how most people do is they make a skin cut, about like 1 to 2 centimeters long. They put something to spread the skin apart. This way, they have space to drill and visualize and put the catheter in. And a lot of people, they literally just, what they do is that they just cut the skin. They do like a single cut of the skin, and they do everything blind. They put the drill in. They cannot see anything. They just drill, and they try to do that to make the procedure kind of, I don't want to say minimally invasive, but
I think as going to the point, it's to get the right point, Coker point. If you do the horseshoe that Arba is saying, it's perfect, especially if the patient needs a shunt. I would love the patient that has an EVD with a horseshoe incision, because the valve goes underneath, it doesn't get infected. But I think in a condition of emergency, and when you don't want to have a failure, because if you have more than one pass, and I always told my juniors and my residents that you have only one pass, because you put that pressure because you want to be successful. More than one pass, then you will increase the chances of bleeding and causing more trouble. So Arba has a good point, but I think it's just to be accurate with a trajectory and to be right to the point, because you can easily miss that point. And we have seen, and I've seen from different places where I trained, misplacement of the EVDs in the length, and when you see it after that the patient is not draped, you feel like how that ended up like that, in the midline, let's say, or how you articulated. So just to be accurate, and Ermal was saying, you want a small incision over Coker point. Everything needs to be right there for you to see it in the middle of the incision. If you do the horseshoe incision, it's great, planning, because if he does a shunt, you already have done the initial work. But I think you can, is the fear of failing the placement of the catheter in the ventricles. And there are places and attendings who encourage the horseshoe or the C-shaped incisions, only because we know that a lot of them, they need shunts.
Thank you so much for clarifying, Dr. Toshkesi and Ahmad.
Diana, do you have a question?
Yeah, hi, thank you for your presentation tonight, first and foremost. It's wonderful to see like representation in our community. So as you were going on about the EVD procedure, I was wondering how a patient presents with hydrocephalus off the bat. How do they, come to the emergency room looking like? How do you confirm that they do have to, in order to proceed with it?
Yeah, absolutely. So when the patient gets to the point where they need us, they usually have already had most of the workup done. But usually the way they present is, patient will present with cold stroke, some sort of weakness, or they're very lethargic. When I mean lethargic, like they were yesterday, the night before they were doing great, they're talking, eating, walking, and then this morning, the husband or the wife or the kids are like, hey, I'm having a really hard time trying to wake them up, they're not really, they're not really responding well. I'm asking them questions, they're not answering. So that's suspicious, So if the patient comes into the ED and has symptoms that look like they're kind of neurologic symptoms, kind of one of the first things that most ED physicians will do is will send them to get a scan of the head. And the CT of the head is quick, takes 2 minutes. And as I said, if they have the symptoms and they have a scan showing that the ventricles are larger than they should be normally for a patient of that age, then that's most of the time that's hydrocephalus. And why would you get hydrocephalus? That's completely other thing that we can go into for hours. But it could be an aneurysm that ruptured within the head. Patient has a lot of blood. Patient has an intraparenchymal hematoma that spread into the ventricles. Patient has a mass or intraparenchymal hematoma that's basically shifting the brain in a way where it's basically causing the normal flow of the fluid. It's basically causing an obstruction within that flow of the fluid. So basically, the fluid just kind of, because of the block, the fluid just backs out and it starts building up and it pushes the brain from the inside out. Those are, some of the reasons why patients come with hydrocephalus. And because we see how they are, because we see the skin, we know that by putting, a catheter in, we can temporarily make them better. Figure out how to basically fix it in the long term.
Okay, thank you.
Okay, if no more questions, well, I really thank you for joining us. And thank you for the presenters, for the moderators. This was really informative. I learned a lot tonight. I also encourage you, anyone who has ideas about Journal Club, to reach out to me, to Sarah, to anyone from AAMS. And if you're not a member of AAMS, please join AAMS. Let's just become stronger and bigger. We need this for Albanian community. We're also preparing some health fairs in the upcoming months. So that's going to be also interesting. And yeah, thank you. Thank you. That was great.
Thank you for having us.
Excellent job. Thank you.
So much.
Thank you.
Okay, have a good night.
Thank you so much. Have a good one.